Good morning, everyone. So delighted to present this on behalf of the co-authors. So work of this scale, sorry, let me fast forward a little bit. Here we go. So work of this scale is a team effort, and there's many people involved with this. There's a large author list you can see. I should also say at the start, I didn't have room for my NIH disclosure form. I work for the US government, I do not speak for the US government. This is personal opinion, and it's not the official policy of the Health and Human Services or the US government. All right. Okay, so really, this study is predicated on really a misperception of how we grade responses in acute leukemia. Our first intent, or the first endpoint we're going for when we're treating patients intensively with acute myeloid leukemia, is for a complete response. And one of the known issues or the secrets over the past 60 years is that there's nothing complete about that complete response. Patients remain at risk of relapse even after achieving the best possible response to initial therapy. And so the typical treatment course for someone who's young enough to receive intensive therapy, young enough to and healthy enough to receive a further therapy, is to take people at the highest risk. So in a complete remission, no evidence of leukemia by cytomorphology and count recovery, to additional therapy to prevent a subsequent relapse. That additional therapy is a bone marrow or stem cell transplant, and is effective in some but not all patients. And so despite the fact those patients go into a transplant in remission, there's still a significant relapse rate post-transplant. So the purpose of the therapy is not met. One of the questions with that therapy is how much therapy we do need to do with the bone marrow transplant. There's really you can lump it into two main groups. Do we do myeloablative, more chemotherapy, or do we do a reduced intensity regimen, which makes the bone marrow transplant more tolerable, but may not have the same anti-leukemic efficacy? And so that was the thinking behind the study. So the purpose of the study is a higher intensity preparatory regimen or conditioning prior to inpatients in AML in a conventional complete remission, so have received their initial therapy, have met that highest endpoint, but have genomic evidence of residual disease before the transplant. Is that going to reduce relapse rates and improve survival compared to a reduced intensity conditioning regimen? So we based this on a large randomized phase 3 study that was conducted between 2011 and 2014 by the Blood and Marrow Transplant Clinical Trials Network, called the 0901 study. So this was a large study that took adult patients in remission from AML and randomized them to either that myeloablative or MAC conditioning, the high intensity conditioning, or the reduced intensity conditioning. That study was actually stopped early, as many of you know. It was reported in the JCO in 2007. Well, the study was stopped early because there seemed to be a survival advantage of those who were getting the myeloablative, the high intensity therapy. And so while the question was the increased relapse rate seen in the reduced intensity arm equally true for all patients who got reduced intensity, or was it just for those patients who had evidence of residual disease by high sensitivity tools? And I'll just introduce here the idea of measurable residual disease. And my one ask is that when you report MRD, you call it measurable rather than minimal. This can be high burden disease, and people are dying of this MRD. And so it's really just disease we can measure, which is just more with higher sensitivity tools than the 1960 response criteria that we've previously been using. And so in this case, we used genomics. We used ultra deep sequencing to look at patients who are in a conventional complete remission by cytomorphology, to see just under the surface there is still evidence of residual leukemia burden, and are those the people who do not benefit from reduced intensity. So the headline results are here. This is survival analysis, overall survival. We now have 49 months of follow-up in survivors. And so for those who had genomic evidence of residual AML before transplant, receiving reduced intensity conditioning compared with the higher intensity form in multivariate analysis was associated with an increased relapse with a hazard rate of 6, decreased disease survival, and decreased overall survival. In those who had no evidence of residual disease before, it was actually very even balance between reduced intensity and myeloablation by overall survival. There's a couple of factors to consider here. There's the mortality from the transplant itself and the conditioning, and those mortality rates are high in the myeloablative transplant, so up to 30% mortality from the procedure itself, versus the reduced intensity where there's a higher relapse rate. Those things counterbalanced in those people who came in without evidence of leukemia in the transplant. So in the NGS negative population, there's absolutely no difference in overall survival between those two approaches. It's only in the people who have evidence of residual disease who seem to benefit from getting myeloablative transplant. And so, my conclusions: the detection of an AML-associated variant using ultra-deep next-generation sequencing in the blood of AML patients in a conventional remission prior to transplant is associated with increased relapse rate and inferior overall survival in those randomized to reduced intensity compared to those receiving MAC.
That's the next speaker coming up, right?
Yeah.
Okay, this concludes your presentation now. Thank you very much. Questions?
Hi, Neil Osterwald, Hematology News. Last November in New England Journal, Washington University and St. Louis researchers reported on genomic and epigenetic changes that seem to occur in patients after with AML that seem to occur after transplant, and think that these changes might be addressed with possible therapies, changes in both adaptive and innate immunity. Have you seen that, or are you looking at that?
Yeah, so we were limited in this particular example of this phase 3 trial by sample availability, and so the only samples that were collected on this trial that were accessible to us were immediately prior to transplant, a blood sample. And the reason we did this particular analysis was these samples were, it was a whole blood tube shipped at room temperature and put in a -80 freezer, so not good for viable cells, not good for looking at the kind of correlation you're looking at. We didn't have any post-transplant. What we would have loved to do is look at exactly those kind of things. So this was Tim Lay in this room's work looking at a HLA loss, and is there an immune escape responsible for relapse? We don't have any of those post-transplant samples to look at. But we'd love, I think, in other situations to try and combine this idea of residual leukemic burden with the idea of immune surveillance and see if there's some combination. We just didn't have the samples here to look at.
Okay, great.
Further questions? Yes, over there.
Hi, Nancy Melville with Medscape Medical News. Hi. I just wanted to ask, I know this advanced sequencing is not available to clinicians, but so in terms of, are there other assays that can be used for this purpose?
Yeah, that's a great question. And I think one of the distinctions I think the European Leukemia Network has been really stressing is that some of the genomic tests we use at diagnosis really aren't applicable to this remission setting. And so the settings, the use of genomics to profile leukemia is now standard in risk stratification. But it only works when you've got a large leukemia burden. And so some of these genomic tests that are currently available can't be used in the residual disease setting. They're just not sensitive enough to be used. And so the European Leukemia Network put out consensus guidelines, which were published in Blood last year, which recommend, in the first instance, quantitative PCR for tracking core binding factor and NPM1 mutated AML, which is probably a quarter of cases, and flow cytometry for other cases. Next generation sequencing is not part of those guidelines yet. I think it may be in the future. I'm part of that committee. But at the moment, the clinical recommendation is quantitative PCR and flow cytometry.